Okay, good afternoon, everyone, and I'm happy to be here just to be the moderator of this very nice session with two major professors that have been discussing and being part of the most relevant evolution of the gynecological endocrinology in Europe and mainly in all the activities of the European Society for Gynecology. The topic today will be around thyroid diseases, and we have the aspects dealing with the reproductive age. Well, the topic is on one side on how thyroid might impair the ability to be able to reproduce. On the other side, we have to discuss what are the main topics and what are the main facts that we have to keep under control when we have a pregnant women and we are following the pregnancy in this patient. Well, Professor Vujovic is the first speaker today. He is the director of the gynecological department in Belgrade, and he has been part of the main meetings all over the world, and mainly for European Society of Gynecology and the International Society for Gynecology. Same thing is for Professor Milewicz, and Professor Milewicz is a milestone for the International Society for Gynecology and Endocrinology, and have been discussing with him in many meetings all over the world. So the first one to start will be Professor Vujovic, and the topic that Professor Vujovic will discuss are the thyroid disorder and reproduction. So please, Professor Vujovic, you can start.
Good afternoon, dear colleagues and friends. First of all, I would like to thank Professor Camille Castello-Branco for organizing all of that and made great efforts for being all of these things as they are. Also, it's my great honor to have a co-speaker, legendary Professor Andrzej Milewicz, who is really one of the most great and very important endocrinologists in Europe. And of course, having chairperson Alessandro, dear friend and great scientific person. So let's start with all of that. Thyroid gland and reproduction. When we are talking about thyroid gland, we have to think about central nervous system and all influences from outside, influencing how hypothalamic peptides, and between them, thyroid releasing hormone, which then influence TSH, thyroid stimulating hormone, which will influence all other things later on in reproductive age of woman. When we are looking at this axis, which is a long lobe axis, then we are coming to thyroid gland and conversion from thyroxine to triiodthyronine in thyroid follicles, which are very important for the homeostasis of that organism of women. In a situation when homeostasis is normal, then it's normal T3 and T4 concentrations and the body temperature will be okay. Otherwise, it will be changed. Yes, and thyroid disorders are most prevalent endocrine condition. Even 14% of adult women suffer from thyroid diseases. Women are 3 to 5 times more likely than men to require treatment, and the prevalence of infertility in them is nearly 50%, so sometimes they even know that they have any changes in thyroid functions, and the risk of premature ovarian insufficiency is high in them. Yes. TRH have direct actions on kisspeptin and gonadotropin releasing hormone, and indirect effects on prolactin and leptin. Otherwise, thyroxine increases secretion of estradiol and progesterone directly in granulosa cells, so it is direct effect on ovaries and pregnancy rates. Thyroid test is test which is not very often done in many clinics, but in infertile women with subclinical hypothyroidism, TSH response to TRH over 20, meaning exaggerated, and we have to think about that hypothyroidism and treating it. Women with increased response to TRH have a lower fertility rate, so we have to treat them before pregnancy. Latent hyperthyroidism is characterized by insufficient response to TRH test. Yes. In peripheral tissues, they include deiodinase enzymes types 1 and 2, which change T4 into T3, which is more biological active. Deiodinase type 3 helps change T3 into reverse T3, which is inactive form. We have to think about some other factors which are biochemical setup for mitochondrial function relevant for reproduction and thyroid functions, and they are magnesium, ferrum, selen, and coenzyme Q10. And when we are thinking about a physiological crosstalk between thyroid and female reproductive axis, then we have to know that any kind of dysfunction and pathophysiology of thyroid gland can induce changes in female reproductive axis. So clinical management of productive age women with this. Erica? And thyroid receptors are present on human oocytes, cumulus cells, granulosa cells, follicular fluid, myometrium, and endometrium with thyroid hormone receptor alpha 1, 2, thyroid receptor hormone beta 1, and TSH receptors. So we can see a lot of receptors in correlation with thyroid gland at the level of ovaries. And when we are looking at the metabolism of all that hormones, they are metabolized from liver metabolism, including deiodinases. And if we are looking at T3 and T4, then we can see that gene transcription is very important, and neurogenesis and migration and synaptogenesis, myelinization in a fetus if everything is okay. Of course, developing brain of fetus and synaptic impairment, hearing loss, visual defects can happen if someone is wrong before, but Professor Milewicz will talk about that one. When we are looking at menstrual cycle and thyroid imbalance effect, then we have uterine lining shedding and irregular or prolonged bleeding in the first phase, then developing follicles. If something is wrong with thyroid gland, it will be delayed follicle growth and absent or disrupted ovulation. And of course, on the other phase of the cycles, low progesterone levels, anovulatory cycles, and there will be no pregnancy. So we have to think about that. Also, deiodinases have degradation in placenta, and we have to think about them later on during pregnancy. TSH receptors are present on immature oocytes, and they have to be activated for the maturation and ovulation. High estradiol decreases thyroid hormones, and low thyroid hormones increase prolactin. So that endocrine milieu in that women is wrong. It's not very good for a fetus and for being fertile. Inflammatory cytokines are very important in the same process, and among them are interleukin 1 alpha, beta, interleukin 6, interferon gamma, tissue necrosis factor alpha, which disrupt the production pathways of thyroid hormones. Interleukin 1 alpha and TNF alpha have peaks during implantation between weeks 6 and 8, and it is coincided with maternal adaptation requirement. Interferon gamma have elevation in weeks 14 to 20, which correlates with fetal thyroid gland development, and interleukin 6 surge in weeks 28 to 36 overlaps with critical fetal brain development. So we have to look about these interferons and inflammatory cytokines during pregnancy also. Placenta is active immune interface between mother and fetus, and increased iodine clearance and elevating deiodinase activity are important. Immunological challenges, pathological barriers to optimal thyroid adaptation during pregnancy, and it alters the expression of specific angiogenic factors and modify maternal fetal interface. So it's very important for later things which will going on. And environmental factors in all those women are important because iodine, iron, zinc, selenium, copper can induce some changes in thyroid gland, then vitamin D, infections, smoking, stressors, then epigenetic factors influencing DNA methylation, histone modification, not coding RNAs, and of course genetic factors, immune-related genes, and thyroid-specific genes. So all of those immunological changes have to be looking at before pregnancy, because if they are not normal, then transitioned immunosuppression can happen and reduce cellular immunity, and immune cells contain receptors for thyroid hormones, so that person can't be fertile. So we have to think about that before pregnancies. And now let's go to thyroid diseases. Von Bazedov in 1840 first described amenorrhea in hyperthyroidosis. Later on, Graves in the USA shown the same things. So the first one was von Bazedov. An incidence of hyperthyroidism and Graves' disease is 1% according to many meta-analyses. Autoimmune thyroiditis is 3.5 per 1,000 women, and 1.4 to 14 women per 1,000 when we are 20 years of age old, and 2025 in women 75 to 80 years old. So it's not the same incidence depending on age. When someone with hyperthyroidism is seen in our practice, then that women can have bulging eyes, goiter, heart palpitations, tremors, heat intolerance, sleep disturbances, weight loss, shortness of breath, diarrhea, increased appetite, irregular menstrual period, and muscle weakness. And then gonadotropins are changed in such a person. LH increase during whole menstrual cycles, but pulsatile characteristics of FSH and LH is the same, like in controls, but LH peak doesn't exist, and hyperthyroxinemia due to exaggerated response to GnRH is present. 2 to 3 times more higher estradiol is seen then, increased SHBG, increased estradiol and decreased estradiol clearance. Testosterone and androstenedione are higher, and increased conversion of androstenedione to estrogen in such a persons. So thyroid hormone increase also catecholamines increasing, oxygen consumption, lipid metabolism, thermogenesis, lipolytic activity due to increased expression of beta-2 adrenergic receptors and cyclic AMP activated hormone-sensitive lipase activity. This is all about hypothyroidism. So we have to think about that. And some 6 months prior to pregnancy, all thyroid hormones must be directed to the normal levels with the therapy of hyperthyroid women. On the other hand, we have hypothyroidism with typical dry hair, puffy face, slow heartbeat, weight gain, constipation, brittle nails, arthritis, cold intolerance, depression, dry skin, fatigue, memory loss, heavy menstrual periods, and muscle aches. And in hypothyroidism, it is flattened response LH to GnRH. And in a case when LH response is delayed, prolactin is increased because TRH increases prolactin and TSH. LH deficiency can be in and low progesterone due to anovulation, low SHBG, estradiol, testosterone, and increased free fractions. Metabolism of testosterone to ethylcholinol is changed. Estradiol to estrone through 17-alpha hydroxylation is present, and estriol is increased in such a patients. Lower clearance of androstenedione to estrone is present, and increased peripheral aromatization. It's decreased 5-alpha per beta androgen metabolites and increased excretion of 2 oxygenized estrogens. Decreased binding of gonadal steroids to SHBG and increased free fractions are present in hypothyroid women wanting to be pregnant. But what's about thyroid autoimmune disease or Hashimoto thyroiditis? TPO antibodies are 4 times more frequent in women with cycle irregularities compared to controls. And very often we can see that it is accompanied with endometriosis and premature ovarian insufficiency. So 25 to 44% of women with endometriosis have thyroid autoimmune diseases, and 27% of PCO or PMO have thyroid autoimmune diseases. So we have always to test them before pregnancy. Infertility and hypothyroidism are very often present, especially subclinical forms. This disturbs peripheral metabolism of estrogens, hyperprolactinemia, defect hemostasis, disturbed response to GnRH, abnormal LH pulsatility, and T4 is necessary for the fertilization and blastocyte development. If a person with subclinical hypothyroidism wants to be pregnant, then miscarriages can occur, premature labor, low-weight babies, hypertension, and rupture of placenta. And we have to make all efforts to prepare women 6 months at least before pregnancy. When we are looking at some characteristics of hyperthyroidosis, then it can be present in late puberty girls, in those with opsomenorrhea, with oligomenorrhea, or amenorrhea, while in hypothyroidosis, precox puberty can be present, menorrhagia, polymenorrhea, and dysmenorrhea also. But we have to think about many stressful situations which women are surrounded by in today's world, full of many expectations, but full of many stressors. And when we are thinking about that, then stressors can influence through hypothalamus, TRH, then TSH, and of course, thyroid gland and thyroid hormones, T3 and T4. And stress responses increase catabolism of glucose to produce ATP. So this is one of long loops of acting stressors through CNS to thyroid gland. If we are looking to all of that, what can threaten homeostasis, and when stressors are included, then from hypothalamus through sympathetic centers and nerves and through adrenal medulla, noradrenaline and adrenaline induce many changes of the health of that woman, increasing in blood glucose and decreasing digestive activity. So it is short-term response. On the other hand, release of cortical-releasing hormone through anterior pituitary and adrenal cortex through mineralocorticoids influence salt and water retention, increase blood volume and blood pressure, and through glucocorticoids increase blood glucose, catabolism of fat and protein, and decrease inflammatory response and immune response. So we have to think about all those things if women are under stressful conditions. Stressors influence immune response, and TSH receptors are included, as well as hormones, neurotransmitters, and cytokine modulation. Defect of antigen-specific T suppressor lymphocytes is partly responsible for Graves' disease, and Th1 to Th2 a change. It's shown in one of our authors in 1998, so before many years. So stressors increase cortical-releasing hormone, and that hormone increases beta endorphin, ACTH, cortisol, somatostatin, but decrease GnRH, FSH, LH, TRH, TSH, T4, T3, and of course, many other changes. So we have to pay attention about stressors and thyroid gland in all women wanting to be pregnant. But what's about males, just to mention them? In women with thyroid diseases, sexual intercourses can be painful and they can have hypoactive sexual desire. While in males, there are ejaculation issues and erectile dysfunction. And both of them can have decline in sexual drive, fatigue, depression, and maybe they don't know about that the thyroid gland is included in all of that. Yes? And in conclusion, I can say that it is necessary to detect FT4, TSH in all women with cycle irregularities. TSH has to be between 1 and 2.5 milliunits per liter at least 3 to 6 months before pregnancy. We have to measure once monthly TSH during pregnancy, and thyroxine supplementation has been shown to restore endometrium receptivity by modulating gene expression, improving oocyte quality and development in all persons with hypothyroidism. And we have to change women's life, making them happy, healthy, and when thinking about pregnancy, they have to check not only thyroid gland function, but all other endocrine glands function. So we have to think about that 6 months before pregnancy, if not earlier, to become pregnant. And of course, endocrinologists and gynecologists have to work together in having more babies in today's world, whatever it is today. And we have to make it better, happier, and healthier place to live on. And it will be my presentation for now, but of course, Professor Milewicz will continue with other things. Thank you very much for your kind attention.
Thank you very much, Svetlana, and thank you very much for this absolutely excellent presentation. We have heard in the best way how relevant is the action on thyroid on all over the aspects of the control of the reproductive issues in our biology, especially in females, and how relevant is also the aspect, obviously, of men. And now the topic is in charge of Professor Milewicz, and now we have the aspects of thyroid disorders and pregnancy. So please, Professor Milewicz, your turn.
So good afternoon, ladies and gentlemen. First of all, I would like to thank to European Society of Gynecology for the invitation and give me the possibility to be with you today. So we continued the problem according to thyroid disorders and reproduction, and second step is pregnancy. I'm preparing the statement according to statement of Polish Endocrine Society as well as European Endocrine Society, the statement how we can make a diagnosis and treat the patient, our pregnant women with thyroid disorders. So as Professor, is something wrong because I cannot. So, I have no financial relationship to disclose. So as Professor Svetlana show you, the thyroid disorders are most common endocrine disorders in women during their reproductive age. Autoimmune thyroid disorders we can affect, depends of the population, about 10% of women population. Hypothyroidism 2 to 3%, and hyperthyroidism in a smaller amount 1 to 2%. So as endocrinologists, we recommend women who planning to be pregnant to estimate its in serum TSH, FT3, FT4 levels, because these are related to taking into account the influence of physiological changes related to, of course, pregnancy, as well as the influence of some medication use, heparin, IVF procedure, or metformin, which have influence for TSH. And for that reason, so we must estimate it free thyroxine and free triiodothyronine levels. So the screening for thyroid disorders is recommended for women planning to pregnancy in the first trimester of pregnancy, as well as for patients treated for infertility. So the levels of TSH, FT4, and T3 is depend of trimester of pregnancy. As you can see, it's a totally different normal levels of TSH as well as T4, T3 in the first trimester in comparison to second and third one. So TSH increase, and T4 also T4 a little bit decrease with the trimester of pregnancy. So it's very important to register this value of TSH and FT3 and FT4 for your everyday practice, because it's very, 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 very important for successful pregnancy and delivery. So not only TSH, T3, T4, we recommend to estimate it in women planning to be pregnant and or are pregnant. Absolutely, we must estimate it also antibody. Antibody against the thyroglobulin, anti-TPO, as well as TRAP, because the high amount of this thyroid antibody is a high risk for miscarriages. You remember about that. That's the pregnancy with high amount of an antibody is a pregnancy with high risk of miscarriages. So what we can say about the most popular disease according to thyroid disorders, hypothyroidism. So Professor Svetlana showed you that the clinical symptom, but to repeat it, fatigue, increased sensitivity to cold, constipation, dry skin, weight gain, puffy face, as you can see on that photos. So the prevalence of hypothyroidism is about 2 to 3%. According to population-based study, the prevalence of subclinical hypothyroidism with TSH elevated and with normal FT3, FT4, we can recognize in 4 to 15% of women, depends on the population. Once more, I come back to the value of TSH, T3, T4 recommended for first, second, and third trimester. So hyperthyroidism, as we can recognize in the first trimester of pregnancy, TSH is between 2.5 and 3.18, and altroxin treatment was not initiated. The patient required careful monitoring. If as the TSH elevated, so we start with treatment, altroxin treatment. During altroxin replacement therapy, the target TSH concentration should be in the lower range of pregnancy-specific reference value, as what I showed you before. If such a value are not determined, TSH concentration should be always lower than 2.5. So according to the treatment, so it's a very simple and effective, so we use altroxin. So what is very important that in the moment when the women start to be pregnant, we must increase the altroxin dose about 20 to 30%. That's the second home message. Remember, if your patient starts to be pregnant, you must immediately increase LH dose by 20 to 30%. So in some cases, we can use liquid altroxin, not in tablet. Mostly it's happened in a patient with gastrointestinal tract problems, and also for children, but pregnant children are not pregnant. But anyway, but people who have a problem to swallowing tablets. So it's happened also in women. So altroxin therapy is indicated for pregnancy planning patient with TSH concentration over 2.5 and standard upper range for a particular laboratory, especially at anti-TPO titer increased value. So after gestation confirmation, LH thyroxin dose, L-thyroxin dose should be increased 30 to 50%. Altroxin dose change when the TSH concentration must be controlled every 4 weeks, and it depends on the levels of TSH. So we modulated the altroxin dose. What is the next home message? Very important. After delivery, pregestational altroxin dose should be reinstituted, and TSH should be checked after 4 to 6 weeks. And next home message, very important, the no contraindication for breastfeeding in patient treated with altroxin. So You must remember also about that some paper recommended treatment with levothyroxine in subclinical hypothyroidism because this author suggests that treatment with levothyroxine registers the risk of miscarriages in subclinical hypothyroidism in pregnant women. So what we can say in contrast to hypothyroidism, to the hyperhormonal activity of thyroid, thyrotoxicosis. In thyrotoxicosis, thyroid hormone are elevated with or without increased thyroid hormone synthesis. The most common form of thyrotoxicosis are caused by excess intake of thyroid hormone medication, levothyroxine, or result from temporary excess release of thyroid hormone due to subaracute thyroiditis. So we can recognize three forms of hyperthyroidism. The first one is Graves-Basedov disease, diffuse toxic goiter. The second one, toxic multinodular goiter, Plumer disease. And third one, toxic adenoma. According to Graves-Basedov disease, this is more prevalent in women than in men, with estimates suggesting that it affects about 0.5 to 2% of general population in women. So, toxic multinodular goiter tends to occur more frequently in older individuals, particularly those over the age 60. The prevalence increases with age, and it is more common in regions with iodine deficiency. So the third form of hyperthyroidism, adenoma toxicum. Estimates suggesting that toxic adenoma account for approximately 5 to 10% of causes of hyperthyroidism. However, the exact prevalence may vary among different populations and regions. Toxic adenoma are more commonly observed in older individuals, particularly over the age 60, and they tend to occur more frequently in areas with iodine sufficiency rather than iodine deficiency. A common symptom of hyperthyroidism and thyrotoxicosis including nervousness, anxiety, increased perspiration, heat intolerance, hyperactivity, and heart palpitation. You can see also the edema, as you can see, typical, and ophthalmopathy in Graves' disease. So, according to diagnosing, hyperthyroidism with thyrotoxicosis are marked by decreased TSH levels and elevated FT3 and FT4. That's typical thyrotoxicosis. Milder hyperthyroidism is when we observe decreased TSH levels and only elevated FT3 levels. And subclinical hypothyroidism features is we can recognize in situation when TSH is decreased and normal levels of FT4 and FT3. Just for memory, again, different normal levels for TSH, FT4, and T3 depend on trimester of pregnancy. So, a very important role play an antibody in hyperthyroidism. Antithyroid peroxidase antibody elevation with autoimmune disease were found in 85% of Graves' patients. Thyroid-stimulating antibody trap, also known as thyroid-stimulating immunoglobulin, long-acting thyroid stimulator, were found in 63 to 81% of Graves' disease. Graves' disease is characterized by significantly elevated anti-TPO and anti-TRAP, Toxic multinodular goiter is characterized by a low or absent anti-TPO and negative trap. Toxic adenoma is characterized by a low or absent anti-TPO and negative trap. Patients without active thyroid disease may have mildly positive anti-TPO and trap. Subacute thyroiditis, low or absent anti-trap TPO and negative trap. Hyperthyroidism and the risk of several adverse pregnancy outcomes. That first is preeclampsia. Second one, superimposed preeclampsia, preterm birth, and intensive care unit admission. So gestational thyrotoxicosis, it's happened, and the frequency of gestational thyrotoxicosis depends heavily on the specific type of gestational transient thyrotoxicosis, being the most common occurring in 2 to 11% of all pregnancy. By contrast, true clinical hyperthyroidism is much rarer, affecting about 0.1%. And then, so you can also to make a photos to how to compare Graves' disease, thyrotoxicosis during the Graves' disease, and gestational thyrotoxicosis. In Graves, we observe elevated trap concentration. In gestational thyrotoxicosis, normal trap concentration. In Graves' disease, high ratio T3, T4, low in thyrotoxicosis, orbitopathy symptom and goiter in Graves' disease, and hyperemesis gravidarum and multiple pregnancy in thyrotoxicosis. Presence of symptom of thyrotoxicosis prior to pregnancy. In the gestational thyrotoxicosis, no symptom of thyrotoxicosis before pregnancy. Family history of autoimmune disease in Graves' disease, and negative family history in gestational thyrotoxicosis. Predictable course in Graves, and usually self-limited thyrotoxicosis in gestational thyrotoxicosis. So, how we can treat the patient with hyperthyroidism and pregnant? Optimum choice of anti-thyroid drugs is rare case of metimazole associated to embryopathy versus risk of proteouracil associated with acute hepatic failure. So both drugs are not so friendly for women's health, but we must treat them. So the authority in thyroidology recommended starting dose of proteouracil 50 to 30 milligram per day, depends of severity of the hyperthyrotoxicosis in the first trimester, and then we switch in second and third trimester to metimazole for 5 to 15 milligram. So I think that is very important also message. Please make notes for your everyday practice if you have for sure in future a hyperthyroid patient with pregnancy. So at the initial stage of treatment, follow-up should be continued every 2 weeks. We must also remember that drugs using for treatment of hyperthyroidism also can damage the function of white blood cells, and we can observe leukopenia, and for that reason, during the treatment with these drugs, please check morphology every week for the first month to check how to check amount of white blood cells. So after euthyroid maintenance, check test should be continued every 2 to 4 weeks. The combination of LT4 and anti-thyroid drugs is prohibited. So that's a home message, also very, very important. There are no contraindication for breastfeeding in a hyperthyroid patient if methimazole dose is not exceed 20 milligram per day and propylethiouracil 300 milligram per day. One more, I repeat. There are no contraindication for breastfeeding in hyperthyroid patient treated with methimazole in dose not higher than 20 milligram and or propylethiouracil not higher than 300 milligram per day. The drug should be taken after the breastfeeding, preserving 3-hour break before the next one. Once more, the drugs should be taken after breastfeeding, preserving 3-hour break before the next one. So, absolutely, iodine treatment, radioactive iodine is forbidden for women with pregnancy. So, achieve thyroid first, according to the women who planning to be pregnant and have hyperthyroidism. The patient with hyperthyroidism should be reach permanent hyperthyroidism before trying to conceive. Also, the truly review available treatment and the impact on pregnancy and fetal development is necessary. So confirm pregnancy as soon as suspected and contact endocrinologist to modify treatment. Consider discontinuing anti-thyroid drugs in the first trimester for low-risk patients. So what we can say if our patient with pregnancy have nodular goiter, and so we would like to make biopsy and ultrasound examination, so we can do we can make the diagnosis, and benign nodule are monitoring per standard guidelines. The surgery only in second trimester is if absolutely indicated. According to papillary thyroid cancer, is also the same story. Require ultrasound monitoring if progression occur. Consider surgery in second trimester. Surgery in both cases. And if TSH is over 2 microunit on conservative management, consider alloxin. So, according to iodine prophylaxis, the general recommendation, so it is recommended that all women living in Poland who are planning pregnancy, are pregnant, or are in the period lactation, took medication or supplement containing iodine in the dose 100 microgram. This is due to fact that the iodine contained in relation to the mass of L-troxin sodium salt molecule is approximately 64%. This means that each 100 microgram tablet with L-troxin containing 64 microgram of iodine. For that reason, so you solve the problem with iodine prophylaxis. So, summarizing my presentation, I hope that the detailed discussion of thyroid dysfunction and pregnancy will be useful in your daily practice, and in developing this clinical problem are relate of guidelines of Polish Endocrine Society as well as European one. Thank you for your attention.
Thank you very much, Andrzej. Thank you very much for this great presentation. And as you have heard up to now, thyroid is something which might sound as a mysterious endocrine gland, but it's absolutely relevant for the control not only for the production, but mainly for the maintaining of
Skończył, tak?
Skończyłem.
To teraz escape
Ale tu nie ma nic,
pregnancy.
escape.
na klawiaturze.
Please, Andrzej.
Tak. Yeah?
Okay. We heard your phone call.
Yeah. Okay. I'm sorry.
We have now some questions from the audience, so
Yes.
I'll try to go through them, and have taken some notes. This one is for Professor Vujovic, and someone is asking, a colleague from England, there are specific nutrients that could be taken just to keep thyroid function under control?
In fact, if someone is feeding, let's say normally, who is not in some extreme situations in nutrition, then it is a normal concentration of all of that microelements or whatever. But in special subgroups of patients who had some nourishing problems or anorexia nervosa or any other problems or being too obese, etc., then we can measure some of that elements and then add them if it's necessary, or even put it together in one capsule like multivitamins or minerals, and not drink too much, not take too much pills of every vitamin or mineral separately, because it's too much for your body.
Okay, that's great. And another question is, in a specific situation with hypothyroidism, someone is invited to take selenium as an oligo element just to sustain thyroid function. What's your idea about this?
When we are talking about selenium, then in a case of subclinical hypothyroidism, it can be of some value, and it can be taken for a longer period. But if it is really hypothyroidism with high level of TSH, then selenium itself can't be the only medication. So it is just one co-medication helping for immunity.
Yeah.
Oh, that's good. That's correct. And now I have a question for Andrzej. When a patient with a problem due to hyperthyroidism is taking tapazole, what is the change that should be done just to move from tapazole to metimazole?
So that's indications suggested recommended by specialists. That's risk of side effect is lower if you start with such a proposal. What I show.
So propyltyrachil is for sure best one in the choice at the place of tapazole. And on your opinion, Andrzej, considering that tapazole is a treatment that might be given from half a pill in a day up to 3-4 pills all over the day, should be propyltyrachil chosen, and the dose is to be controlled up to have the lower levels of TSH?
So for sure, the TSH is one story, but most important is estimation of FT4 and FT3, because the TSH start to be normal for a long time. It takes a long time. It's time consuming. and FT3, FT4, we can normalizing earlier, and that means that we can reduce the not friendly drugs for our patient, and it's much more safety for patient. For that reason, so I recommend FT4 and FT3 estimation in such a cases as a most important one.
Okay. There is a question for the hyperthyroid situation. In thyroid storm, we give the patient a loading dose of propylthyroxine. Were there any reports that that dose causes hepatic failure?
What we can do in hyperthyroid, because I don't understand which medication. So
no, the propylthyroxine is something that might induce hepatic failure or hepatic diseases. There are consistent literature on this.
So I'm sorry, so I cannot answer about that question.
Maybe I can add if I can. Can
Yeah,
I?
sure.
Yeah.
Yes. Never in my 30 years old practice, I've seen hepatic failure in such a patients. So if it happens, it's so rare that it's really very rare, because I'm working in the biggest clinic of endocrinology. So many patients had it, but it is really a very, very rare situation. I have no one patient like that with that.
So
Okay.
for the other way, the non-alcoholic fatty liver disease frequency dramatically increased in women during last 10 years. For that reason, so we might be very safe, because so we can check the liver function during news, not news, but a home message for doctor to check the liver enzyme in the patient who are treated for hyperthyroidism.
Okay, that's a good point. There is a question for Professor Vujovic, and you have discussed the intriguing of prolactin with thyroid. So whenever we have hypothyroidism, we have the chance of getting high level of prolactin. So in addition to the use of levothyroxine treatment, what is the use of dopamine agonist to lower prolactin?
Very often that levels of prolactin are a little bit higher than normal. So they are not extremely great values of prolactin in such a patients. And when we fix normal values of thyroxine and of course add drugs for treating hypothyroidism, prolactin is going down. So it's necessary to use dopamine agonist in the very beginning. And then when the normal concentrations of FSH will be reached, then we'll check, of course, prolactin and see what's going on. Because sometimes that women are under stressor conditions and have some other reasons for having higher prolactin. Or maybe it's not measured on appropriate weight, meaning they are going to lab very quickly and take prolactin at once, not sitting, not being in rest some half hour before taking blood analysis. So the talk about prolactin is depending of the way of taking analysis, and of course when TSH is normal, then we expect that prolactin will be normal too.
Okay, that's correct. Interesting. And there is another question in regards to prolactin for the topic of the linkage of prolactin with the thyroid. If a patient has a high level of prolactin, which is kept under control just before pregnancy, this is for Professor Milewicz, I think. how can we move from cabergoline to other dopamine agonists in treatment with levothyroxine? Should we choose other treatment? I think that this colleague is talking about bromocriptine.
Yeah.
What's your opinion, Andrzej?
No, I agree with you, and I think that at first, so now the people who ask us not say that he's a microprolactinoma or some is a tumor in pituitary or the functional hyperprolactinemia or macroprolactinemia also happened. It is depend of this type of hyperprolactinemia. So we use a different treatment, and for that reason, so I think it's difficult to answer strictly because we don't know what mean elevated prolactin. It's a 25 nanogram per ml or 100 or 300. It depends of that, so we can decide it what is more important for women to be on life and or to be to successfully finishing pregnancy. So it's a topic for this long discussion. I think it depends of situation.
Okay, that's interesting. Well, there is another question in regards to the reproductive function in the normal menstrual cycles and in the normal, let's say, ruling out the ovarian functions and ovulation. How should we keep prolactin and thyroid under control when we have subclinical hypothyroidism and minimal levels of prolactin above the normal range, when we have to induce ovulation?
Sometimes a little bit higher prolactin than normal prolactin levels are due to stressors and way of life of that women. So I like to add low doses of anxiolytics before pregnancy. I'm talking about that period 6 months before. And then prolactin is perfect and they are relaxed, and that's okay because everyday life is very stressful because women are working for 5 women, not for 1 woman. So it's not so easy to be all of that person, the best one, as many of us are trying to be. So sometimes adding of anxiolytics can make prolactin at the normal levels. When we are talking about subclinical hypothyroidism, then it depends, is that woman looking for pregnancy or not? If she's not looking for pregnancy, we can wait until TSH is 10 units per liter, and then if it's over, we add drug. But if she's looking for pregnancy in the next 6 months, we have to reduce level of TSH at the level of 1 to 2.5 because we are creating environment in the ovary and influencing quality of oocytes to be the best before pregnancy, and then continue with all of that.
Okay, that's interesting. Do you have any suggestion in addition, Andrzej, on this? You are endocrinology, a pure endocrinologist.
No. I show you in my presentation that in cases of subclinical hypothyroidism in pregnant women, that for safety of pregnancy, it is better to treat the patient with altroxin dose to try to normalizing the TSH levels to be normal because of risk of miscarriages. For that, I don't have personal experience, but for the literature, so I show you during my presentation.
And maybe I can add that as I have many of such patients, that TSH is very important for the quality of oocytes. Very often you can hear from some doctors that say to women, you have bad oocyte, or you are too old and your oocytes are too bad. But oocyte is full of various receptors, and if we change all of that to normal values, quality of oocyte can be much better. So we have to do whatever we can do to improve oocyte quality, and it is possible, really, but not for just 1 month. Only 6 months at shortest period or longer. So we have to create a nice environment for pregnancy.
Yeah.
That's correct. Now I have a final question, which is quite intriguing. You know that women are in some cases quite dangerous, because a colleague is asking that there is, but this is also in Italy, there is the common attitude to use levothyroxine just to improve metabolism and try to lose body weight. So is such kind of way of doing a problem in the control of the ovarian cycle and ovulation and in good health in women that do not have any thyroid impairment? So the final points from you.
As endocrinologist, I not recommend you L-troxin treatment for obesity, because we have too many other very successful drugs. And so that's an old-fashioned mentality. It's happened historically many years ago, that people are using. It's so because they use mostly a small dose, so it's not danger for health. But of course, in cases where somebody have some also for nodular goiter, so we're using L-troxin to try to decrease the size of the nodule. In my opinion, it's absolutely don't make sense.
Okay, and your opinion, Svetlana?
My recommendation for patients, please don't do it. And there are another group of bodybuilders. They like to do it all the same, and please don't do it, because there are many other problems. So we can solve problem on another much better ways.
Okay. Well, so we have no other questions. So the session it has been very interesting, intriguing, and I have to say that thyroid is absolutely a relevant endocrine gland that we have to keep under consideration whenever we try to focus on the ability to control or to improve the ovarian function. And obviously, we are gynecologists, but we need to have a little bit of skills on the use of hormones in the keeping hormones under control. And so before leaving you for this afternoon, I would like to remember that in 2027, in March, in between 17 and 20 of March, we will have the 16th Congress of the European Society of Gynecology. So I would invite you to join us for such a relevant event, because we will discuss a lot of issues. Many of these have been discussed on the webinars, but for sure, meeting with people is the best way to exchange ideas, to exchange improvements in the skills, and it's a good way to keep in touch with friends. So thank you, Andrzej.
Thank you.
Thank you so much.
Thank you
for having been with us, and have an incredible good afternoon, and see you in the next meeting on site together in person.
Always together.
Ciao.
Bye. All the best.